10-minute rule motion, David Duguid.
Thank you very much, Mr. Speaker. I beg to move that leave be given to bring in a bill to require the Secretary of State to conduct a review into the George (22q11 Deletion syndrome, to require the National Health Service to publish a strategy after the review is complete and for connected purposes. Mr. Speaker, this bill would, as the long title reads, place a duty on the Secretary of State and the Department of Health and Social Care, in consultation with the National Health Service and key stakeholders, to conduct a review into the diagnosis and treatment of DeGeorge syndrome. Those stakeholders should include sufferers of DeGeorge syndrome and their families. The bill would also require the NHS to develop and publish a strategy for DeGeorge syndrome after this review has concluded. Mr. Speaker, for the purposes of this bill, I have referred to this condition as DeGeorge syndrome, with 22q11.2 Deletion syndrome in parentheses, as DeGeorge syndrome is the name most commonly used by the NHS. However, because the signs and symptoms of this syndrome are so varied, different groupings of its features have historically been regarded as separate conditions, under a variety of different names. These conditions are now understood to be presentations of a single syndrome with a universally accepted nomenclature of 22q11.2 Deletion syndrome. For brevity, you'll be glad to hear, I will refer to the condition as 22q from this point in my speech. 22q is a genetic disorder caused by the deletion of between 30 to 40 genes in the middle of chromosome 22, at a location known as 22q11.2, hence the name. 22q is often referred to as a rare genetic condition. However, as the second most common chromosomal syndrome after the much more familiar Down syndrome, it is unfortunately not as rare as the little-known name might suggest. Estimates range, or have ranged, from between 1 in 4,000 to 1 in 2,000 of live births, although due to the lack of familiarity of this condition, this is expected to be an underestimate. In fact, recent estimates bring estimates into as common as 1 in 1,000. 22q is often described as the most common genetic syndrome you have never heard of. Everyone with 22q is affected differently, and most children with the condition survive to adulthood and enjoy a relatively normal lifespan and independent life. However, 22q can lead to a range of health issues which can affect quality of life and even shorten lifespan. Congenital heart disease is a common concern, as well as defects in the palate and a range of learning difficulties. Worryingly, children who are born with 22q and present with learning difficulties are often misdiagnosed as being on the autistic spectrum. However, studies have shown that although some of the developmental symptoms may be similar, the causes of these symptoms are quite different. This common misdiagnosis often leads to 22q patients receiving the wrong kind of care and support, with potentially disastrous effects. Because the different treatments offered can be as varied as the root causes themselves, children with 22q often develop other medical issues, particularly concerning mental health, which could otherwise have been avoided if diagnosed correctly. Mental health issues are very common among patients living with 22q, particularly if diagnosis is missed early on. In 22q, patients' mental health issues often present themselves at a much earlier age than in the general population. Schizophrenia, for example, normally has an occurrence of around 1%, whereas in the 22q population, this is estimated to be closer to 25%. When I first became aware of this condition, one of the concerns which surprised me the most was the relative lack of familiarity of 22q among not only parents and educators, but also those in the medical profession, particularly in general practice. Because of this, many symptoms go unnoticed until they have already progressed considerably. And it's this blind spot that not only incurs additional costs to the NHS in the long term, but also has a terrible impact on the patient, their family and carers, as well as affecting employment, quality of life and mental well-being. Early detection of 22q provides the opportunity of earlier intervention and management of the condition, which can significantly improve the quality of life of patients and their families. At this point, I'd like to pay tribute to the charity Max Appeal. Max Appeal do a huge amount of very valuable work on 22q. Max Appeal, they have produced a paper which argues for the introduction of a screening programme for 22q that provides earlier diagnosis of affected individuals, in turn reducing morbidity and possibly even mortality. For a relatively small cost, such a screening programme would help to keep overall healthcare costs down, due to the early detection of potential related issues and complications, as I've previously mentioned. 22q can be detected through a simple heel prick test, which is already offered by the NHS to babies around 5 days after birth. The test entails pricking the baby's heel and collecting 4 drops of blood, which are then tested for a total of 9 conditions currently, including the more well-known sickle cell disease and cystic fibrosis, among others. At the moment, no screening for 22q is performed routinely on the blood collected through heel prick testing. Any blood tests to check for 22q are only done to confirm a diagnosis when another symptom prompts clinicians to do so, such as in the case of a cleft palate or heart defect. Clearly, this approach cannot be relied on to catch all cases, in part due to the surprisingly low awareness of the condition among GPs and other medical professionals not specialised in the field of rare genetic conditions. The UK National Screening Committee do not currently have a recommendation on screening for 22q, although some work on this has been done in the United States. A 2014 study published in the journal Clinical Chemistry, for example, found that blood spot tests would be a promising approach for newborn screening of 22q. A 2017 study in the Journal of Clinical Immunology looked primarily at the screening of severe combined immunodeficiency, or SCID for short. This study discussed the potential introduction of newborn blood spot testing for 22q, and the authors of the study concluded that, and I quote, "Assays which screen for 22q11.2 Deletion Syndrome using dried blood spots have been developed and proven to be effective and efficient. Population-based studies should be completed to demonstrate the efficacy of these assays on a larger scale. However, the clinical characteristics, diagnosis, management and treatment of 22q11.2 Deletion Syndrome have been shown to meet the criteria for newborn screening programmes and support the need for earlier diagnosis." Screening for SCID is currently being trialled in the UK, and it's believed that this could be extended to be a 2 birds in 1 stone approach to trialling screening for 22q. Max Appeal have produced a paper, as I've mentioned, which I hope the Secretary of State and the relevant ministers of the department will consider reading, which argues the case for this. I know that ministers and fellow members will be as concerned as I was to learn of the struggle facing 22q patients and their families, and it is for this reason that I am asking this House today that leave be given to bring in a bill to require the Secretary of State and the Department for Health and Social Care to conduct a review into 22q and to require the NHS to publish a strategy after that review is complete. Whatever the outcome, this would be of real value and of real reassurance to the thousands of families around the UK who are affected. There is so much that we can do to help these families in a sensible, proportionate and cost-effective fashion. Finally, Mr Speaker, I would like to invite the Secretary of State, his ministers at the Department and any honourable members who would like to hear more about this issue to attend the next meeting of the All-Party Parliamentary Group for 22q11.2 Deletion Syndrome, of which I am the Chair. Our next meeting is on the 26th of June, and I know that Max Appeal and the families they represent, who are spread across the country in many colleagues' constituencies, would be very grateful to see them there. Thank you.
Thank you. Order. The question is that the honourable gentleman have leave to bring in his bill. As many as have that opinion say aye. Aye. Of the contrary, no. I think the ayes have it. The ayes have it. Who will prepare and bring in the bill?
Heidi Allen, Robert Goodwill, Alex Sobel, Norman Lamb, Jack Lepresti, Vicky Ford, Melanie Onn, Jim Shannon and myself.
Very good.
Mr David Duguid.
David.
Duguid Syndrome, Review and National Health Service Duty Bill.
Second reading what day?
26th October.
26th of October. Thank you. Order. Colleagues, we